a tremendous triumvirate. Oh, I say got it? Oh my God. Still hear me?
Yes,
Hello?
we can hear you.
Okay.
Yes, we can hear you.
Okay, I'm so sorry. It's me. Okay, tremendous triumvirate of colleagues to present this very important topic, and I'm going to try to whip through my slides as within the time frame. So with regard to percutaneous endoscopic approach, there are really two types of tubes and two types of techniques. One's a push and a pull. I'm going to tell you about that. I'm going to briefly run through the benefits of endoscopic gastrostomy and, strikingly, its complications. There are two types of approaches. One is a pull technique, which we employ, and the other is a push technique, which is really what Robyn is using with her radiological intervention. But there's an endoscopic push, and I'm going to show you what those are all about. The indications from our perspective are for enteral access because of a malignant obstruction or rarely benign obstruction, people who can't eat because of neurological problems. And then we are involved with a drug delivery system using duodopa for Parkinson's disease. So we do put PEG and then jejunal drug delivery tubes that way. And rarely, when people are obstructed, we can use a PEG for venting. Now, this is one composite slide of all the push technique, and Robyn may talk about this in greater detail, but from the endoscopic point of view, we fill up the stomach with air and we watch the needle puncture the stomach through the anterior abdominal wall. And this technique differs because there is a trocar that dilates the tract. And through that tract, you then push the PEG, the gastrostomy balloon, inflate it, and then you retain it. So the problem here is that there's a bigger hole made to establish this feeding gastrostomy. And that may be one of the issues we can talk about that lead to greater complications with this technique versus our pull technique. Our pull technique, we do gastroscopy. We see a site of maximal transillumination on the anterior abdominal wall. We then push to make sure there's nothing in between the stomach and the abdomen and the abdominal wall. And if you see light, you go. And you see this from the inside. But basically, we make a little tiny incision. And then we see the puncturing of the needle through the anterior abdominal wall. We have the trocar through, and then we pass a guide wire after we grab the catheter. Here's the guide wire coming through the catheter. We grab it and pull it out through the patient's mouth. And this is a setup before we pull the G-tube down through the mouth, and then with the retention bumper resting up against the anterior gastric wall. So this is the pull technique that we establish, and this is the end of it, and it's all dressed. Okay, so let's talk about outcome benefits. Well, quite a bit of the literature I'm going to talk about is our local literature. This is Elaine Poslin's group that when she published in 2012 at an Aspen presentation, a poster presentation, we only looked at about 52 patients, 31 PEG and 21 control non-PEG head and neck cancers. Now, the data are mostly qualitative, not a lot of rigorous statistics here, but let me do some qualitative information. There was arguable reduced weight loss with the patients who received a PEG versus non-PEG, not as dramatic as you would think. So I thought that was quite interesting. But most importantly, there were no treatment interruptions with the PEG patients versus the control patients, and there were no hospitalizations. About 24% with the non-PEG patients. I'm not sure why that was. I couldn't break out that literature. I don't know if Elaine's on the line, but there seems to be a significant difference between the patient care with and without a PEG, that there are less treatment interruptions with PEG and less hospitalizations with PEG. And this was corroborated by another author in the same year. Also, our group, the nutritional group led by Osborne, published in the same year, a retrospective questionnaire. Again, nice qualitative data saying, well, how did the patients feel with it? Well, 90% felt that it was a worthwhile experience. 84% had a much better quality of life in the same patient population than compared to the non-PEG group. And weight loss was quite variable. Suffice to say, there was no significant weight loss difference between patients who had a PEG and those who didn't have a PEG, which was kind of dramatic for me. I thought that we were doing this to prevent weight loss and enhance nutritional support, immune function, etc. Doesn't seem that PEG is doing that, but we'll see what the discussion is. So this is a very busy slide. I'm sorry for it. Basically, what are the complications now? The phase of discussion on complications, minor and major acute complications. Minor, like bleeding at the site, ileus, pneumoperitoneum, they're all pretty minor. Major would be a colocutaneous fistula. Now, thank God it hasn't happened to us. We have had one major bleed from a PEG placement a couple of years ago. The stomach somehow rotated. We hit a gastric artery, and Fred Brenneman was in the neighborhood. He took him right to the OR. So that was our only serious complication acutely. Chronic complications tend to be minor, wound infection, leakage at the site, but the major one is tumor seeding, and we're going to talk about that. Overall, acute 24%, chronic 26%, sort of in that area, but most of them are innocent and nuisance disorders. I put a list of all the references. The two top references I listed in bold are our colleagues here in Toronto, Sunnybrook, and surrounding hospitals, and we'll show you some of their data. So I'm just going to compare endoscopic versus radiological G2 placement. And this was a publication by Park in 2019. They looked at 324 PEG placements and 94 radiological placements. The minor complications were similar in both. Major complications seem to be a little greater in the radiological PEG placement. But the big one that's alarming is the potential for metastatic spread by doing a pull technique where I pull the scope, pull the PEG down through the patient's mouth where the oral pharyngeal esophageal malignancy is, picking up cells and seeding the tract. Let me show you what the data are regarding that. With regard to infections, acceptable, 10 to 16% minor wound infections. There are case reports of serious infections like necrotizing fasciitis and candida cellulite. They're just case reports. Aware, but not too alarming. If we give pre and post antibiotics, we diminish this risk significantly. So this is an overall slide of complications, infections. I mentioned 16%. Push versus pull, about the same. Stomal leakage, a significant increase in those who have the pull technique. In the push technique, I mean like the radiological tube versus the endoscopic. Much more stomal leakage. Why? Because the tract is bigger. And so there's a greater access to leakage. Pneumoperitoneum is expected, and it's innocent, benign, rarely is symptomatic, so it's just something that's observed. The rare trauma for blood vessels, liver, colon are rare. The big thing I want to focus on now are two things, tumor and mortality. Let me just jump to mortality. It seems that, Robyn will help me with this, but our endoscopic 18-month or 30-day mortality is about 5%. Now, thank God here in Toronto or at Sunnybrook, we haven't had any mortality as I know of, unless I haven't seen any, but I haven't been aware of any PEG mortality within 1 month of procedures. Radiologic in the literature is 10%, twice as much compared to endoscopic. So I don't think that's our experience, and Robyn will corroborate that. But let me just talk about the thing that is alarming to me is tumor seeding. It seems that the pull technique is greater than the push. Like our endoscopic technique, more than Robyn's technique, is a greater risk for tumor seeding. Why? Because we're pulling the tube down through the tumor, grabbing cells and feeding it through the tract. So our colleagues, David Forner, reported a 0.32% risk versus no risk with the radiological. So the pull, our endoscopic technique, all less than 1%. But still, there is a difference between the pull versus the push technique in seeding of the tract. Fung reported in 2017 a 0.64% with the endoscopic pull versus no percent with the radiological push. Our experience here was 0.32% with the endoscopic pull, none with the radiological push. However, Jennifer Sue also did a survey, a meta-analysis, and found that, well, there are a few cases of seeding of the tract with the push technique. And I'm not sure why that was, whether, I don't know why. I don't know why. It seems it shouldn't happen, but there were. Now, also, if you, Ehrlichman showed that if you actually do some cytology of the tract after the PEG, you have malignant cells in the cytology up to 22%. Whether that evolves into tumor seeding, I don't know. but clearly the seating is an important parameter in terms of patient care. The other risk in terms of tumor seating is the nature of the tumor itself. Obviously, if the tumor is in the pharynx, esophagus, that you're pulling through tumor. If it's a squamous cell cancer, it's greater risk. Poorly differentiated histology, greater risk. If it's bulky, there's more tumor to pull down through the tract. And should it happen, it's a disaster. Survival is about 7 months after metastatic spread through the tract. So I'm going to leave this last slide for hypothesis. Should the radiological gastrostomy push technique be for patients with oropharyngeal esophageal cancer support? And should we reserve the endoscopic gastrostomy for all other reasons for enteral access? And I'm saying that knowing that I could lose a job here, but I just wanted to raise that possibility based on the fact that there seems to be a rare but definite risk of seeding the tract with a pull endoscopic feeding gastrostomy versus the push radiological gastrostomy setup. So that's what I have to say. I hope.
Wow, that was yeah, that was fascinating. Actually, I wonder if that mortality rate was really an all-cause mortality, because 5 to 10% mortality rate after feeding tubes sounds a little high.
I guess it must be. I mean, I'd have to ask our oncology colleagues. Are they seeing mortality for all cause?
I mean, 1 in 10 to 1 in 20 dying within 28 to 30 days of us putting in a peg sounds like it's probably because of progression of disease. I don't think it's because of complications of their tube. That's not what you're. Is that what you're saying?
These are all, yeah, they're not. These are in the peg patients versus the radiological, but not definitely related to the procedure. Right, quite right.
Yeah.
All cause mortality. I should change that slide. You're right.
And anyway, yeah. So I never thought of seating, but that's actually pretty interesting. Now, would I be able to share screen? I guess if maybe if you stop sharing, then
okay.
What I
yes, a good idea.
And I can.
Thank you.
No, actually, sorry. All right. Do people see my screen?
Yeah.
Yi, do you see my screen? Palliative options.
Yes, we can see it. Yeah.
Great, thank you. So I was going to take a bit of a different approach, only because my scope of practice is really mostly dealing with esophageal cancer. So I was very interested in that conversation about seating and the pull technique. So I'll talk a little bit about dysphagia, just because, to be honest with you, that's what I thought the focus was going to be on. And just following that last conversation, talk a little bit about kind of our thought process when we start palliating patients, especially with esophageal cancer. So I'll just talk about when I dilate, when I stent, and then when I choose a feeding tube and what kind of feeding tube we actually want to prefer for these types of patients. As a matter of disclosure, I have nothing to disclose, and absolutely everything that I'm going to present today was plagiarized from people that are far more experienced and smarter than I am. And I actually think to have some of Dr. Cohen's pictures as well. So dilation is the first step that we always try to use. And really, if there's a lumen to negotiate, so if they are swallowing even a little bit of their saliva, patients, or if they're tolerating even minimal amounts of liquids, that's good enough, because we can then thread a guide wire, and that's really all we need. And there is some prediction of success if we can palliate patients' dysphagia with just dilation, and a fibrotic tumor is going to be far more responsive than a soft tissue or a fungating type of tumor. And circumferential disease is far better than non-circumferential disease. And that's because when we dilate, whether it be with a balloon or with a bougie, and a bougie is becoming less frequent, the radial force is usually uniform in a circumferential fibrotic lesion, and then you get a fracture point. But if you have a rigid tumor on one side and a very compliant, soft and pliable side of the wall, then there will be a disproportionate pressure, and there's a higher risk of perforation. However, that is more compliant, so it just basically bulges. So the balloon, instead of actually deploying and causing uniform pressure, it actually goes off to the side, and we rarely really dilate the lumen. And so the patients to screen right will usually have less of a palliative outcome improvement, I should say, than the patients on screen left. Risk of perforation, whenever we have fibrotic lesions post-treatment, and that's usually radiation. Chemo is rarely a problem unless patients are cachectic and doing extremely unwell. But if it's usually after radiation, and that's not because of the fibrosis just at the tumor, but also because there's an amount above and below the tumor, because there's a margin. And then basically it's a much longer area that you're trying to fracture, and that's why it causes a higher risk. Bougie dilatation. Some of us older school people still use bougies. We're very selective, and that's because the bougies do provide two forces. There's a radial force, but there's also a longitudinal force. So there's a shearing force because it's a wedge that goes through, and so there's a lot more force there, and there's a higher risk of perforation. Usually in experienced hands, the risk is roughly the same, but all users, the risk is far higher with bougie. I put experience there, and that's because we do know that centers that do higher volumes of dilatations have a lower perforation rate. So we just want to be careful about which centers and which individuals are actually doing it, because again, there is a bit of a feel to how these dilations should really go. I want to focus a little bit on stenting, because that's probably the only alternative to putting in a feeding tube that many of us discuss. And stenting is really not all it's cracked up to be, and I'll explain why. First of all, stents are no good for proximal esophagus. So usually within about 2 to 3 centimeters of the cricopharyngeus, if there is anything there, so if the proximal aspect of the stent is there, it solicits a huge somatic response. Patients gag, they hypersalivate, nasal congestion, they will retch. It's extremely difficult to tolerate. And so for the proximal deployment to be very close to cricopharyngeus, and that is even the upper constrictor, so not even the lower, but anywhere around the retropharynx within 2 centimeters, that's really a no-fly zone. Sometimes we're close to it, and what we'll do is we'll monitor patients in the recovery room. If they open and start to retch, we just bring them right back and just take out because we know that that's not going to improve. The middle part of the esophagus, that's really yellow. I mean, with caution. It's usually really great to deploy the stent because both the proximal and the distal purchase are within the esophagus and allows for a very, very good deployment of the stent. Usually there's a very good waste if it's a bulky tumor, and so the stent has got a very low risk of migration. So that's great. But big bulky tumors, and we discuss this sometimes at tumor board, in the middle of the esophagus, you have to be careful, because what's on the other surface? Membranous trachea and then the trachea. So what happens is when you deploy a stent in the middle or the middle third of the esophagus, and that's usually between 15 and 25 centimeters from the incisors, because carina is roughly around 25 centimeters, that tumor will then be displaced circumferentially, hopefully, but when it gets displaced, it will displace the membranous trachea. And we have had instances of when we deploy a stent, big bulky tumors, and I mean 5 centimeter bulky tumors, they can completely or almost completely obstruct the trachea. Patients can wake up with stridor. They can wake up with acute respiratory crisis. So we just have to be very careful. And so for those patients, big bulky tumors, if the airway is already compromised, do not recommend a stent. So the best part is in the distal esophagus. But the distal esophagus, you run the risk of the distal aspect of the stent kind of poking into the stomach. And then there's a problem there because it can cause erosive changes to the esophagus. They can have a higher incidence of bleeding in the stomach, higher incidence of bleeding in the stomach. They can have ulcerative changes, and then it becomes problematic. So that's retroflexing of a particular example of a patient. And you can see the healed scar where the scope is kind of obstructing there. In this case, there's a patient who had GI bleed after their stent insertion. So you palliate their dysphagia, but unfortunately, you're giving them different problems. And so anything in the middle third and distal third of the esophagus is probably best for the deployment, but the stents are always fraught with complications. There's all kinds of stents. The only ones that we really have are the covered or uncovered. There's a whole new generation of biodegradable stents that people are getting very excited about. From as far as I can see, not really good for palliation of dysphagia in cancer patients. They sometimes use them for patients that are preoperative. And so hopefully by the time you get to surgery, they've dissolved. There's, I think, a lot of more data to come for those types of stents. So we don't carry them, so it's not an issue for us. I don't know if you guys have them at Sunnybrook, but we definitely don't have them. We don't use them. We tend to use the partially covered stents, and that's because the middle part is covered and allows for good deployment and removal and displacement of tumor, but the distal and proximal skirts are uncovered and allows it to ingrain into the mucosa and then allows some purchase. We tend to use the distal deployment technique because we do it in the operating room with C-arm and fluoroscopy, and we visualize it with fluoroscopy. But obviously, the distal deploying stents are excellent for endoscopic deployment. We don't use the vinyl. Even though they are still available on the market, we no longer carry them and we no longer use them. They have with them a very, very high rate of displacement, and they very often they basically get peristalse them into the stomach and out. Basically, we just always used to call those $1,000 bowel movements. So we normally don't put in the vinyl ones. So we just put in the metal. The metal ones are nitinol, so they are okay for MRI. They are okay for CT. They do cause a lot of artifact, but they don't scatter like, our clips and like hardware. So they're good for CT. They're safe for MRI. And the ones that go into the distal esophagus, there are ones with a valve so that you have less reflux. We don't put those in. We did actually carry them at one point. We stopped carrying them because there was a recall. There would be people that had significant amount of buildup of food, and so the valve would get blocked. And so we were scoping and dilating people that had stents. And so we had a series of about 4 or 5 in a row, so we stopped. We have not re-explored that option, but just so that people know, we no longer carry them, and we may explore that in a year or two if they change the technology of the valve. So those are 2 perfect examples. What keeps the stent in place is that waist. So you deploy and then you see that nice waist of the indentation of the stent. That's a perfect deployment. And then those patients have almost no risk of migration of their stents. Sometimes we clip. One thing that we need to remember, stents are not forever. They're excellent for patients who have a life expectancy less than 6 months. They're really good to last up until then. If you're trying to remove a stent, usually 6 to 8 weeks. I've done them up to about 12 weeks, but they become extremely difficult. Even the fully covered become entrenched and sort of covered with a lot of debris, mucosa, and granulation tissue on either end, and they're quite challenging. Stents do fracture, and this is a perfect example of one that was put in for palliation. You can see it's actually pretty new. That was within, I think, 6 weeks of putting it in, and it fractured, and we had to take it out piecemeal, endoscopically, luckily. The other problem is stents erode. So for all of us that put them in, we need to have follow-up, and you need to really make sure that they're on top of these patients. So that's a perfect example right there of the proximal purchase eroding into the membranous trachea. And so that's a person who actually has a tracheoesophageal fistula proximal to their stent, proximal to their malignancy. That is not a survivable complication. That's just something that we're not going to be able to help with. And that stent was unable to be removed because the tumor was growing into the middle aspect of the stent. We don't like stents. Stents are really meant for end-of-life care. We had a whole experience, and you can speak to it, where we used to put them in for patients preoperatively, but the timing had to be just right, and patients were getting, we successfully were able to do patients with stents and chemoradiation and surgery, but I would say that has to accompany very good communication between the teams to ensure that the timing is perfect, because if those patients wait 2-3 more weeks, they can turn into a non-operative situation. So feeding tubes, if 1 and 2 fail, tubes is definitely the way to go. I think as a group, we underutilize them because of the fear of the possibility that they may not make them, may jeopardize the surgery. In fact, that's not necessarily true. I think insofar as for palliating patients, nasogastric, nasoduodenal, nasojejunal feeds are very, very fast. They pose the lowest risk, but they are definitely the worst palliation, and really only for inpatients and to temporize until we can get interventional or other enteral access. I think that the gastrostomy options, and I think Dr. Cohen went through it already, and I think that's an excellent presentation. I think they're definitely the best way for long-term management. I think the risk is really moderate to low. And the good thing is that this can be done as an outpatient. Sometimes CCAC insists on these patients to be in hospital to initiate their feeds if they've been feed naive. But we've actually had quite a bit of collaboration with CCAC, and we now do them as outpatients as long as we can set up the home care, the feeds, and the dietitian to go into the home. So we've been successful in having these done purely as outpatients. So that's something to really emphasize. The thing with surgical patients that we always get concerned about is if the PEG is done anywhere that's within where we're going to create the conduit, it becomes a problem for surgery. So remember what we remove. We remove the proximal stomach, most of the lesser curve, and all of the thoracic esophagus when we do our esophagectomy. So if you look at this, and that's a picture of intraoperatively, that's sort of the staple line. You can see the proximal stomach, and then this is the greater curve of the stomach. And this is basically the gastroepiploic artery that goes along the greater curve. So right around here. So basically, if it's in the proximal stomach or in the body of the stomach, it's usually safe and will not impact anything in surgery. But if it's over the greater curve, close to the gastroepiploic, then this conduit's going to be compromised. Or if the feeding tube hole winds up, and this is the gastroepiploic, but if you wind up having the gastrostomy hole here, and it in any way leaks, it's now going to be pulled up into the retrosternum. So it's going to be basically a mediastinal leak. And that's a horrific complication. So that's why we get really nervous. However, I think that it's still totally safe to have the conversation about a PEG tube, as long as the interventionalist or the gastroenterologist knows that this is a preoperative patient, then they can gauge a little bit better where they're going to put the tube. I think the other thing that we tend to advocate for is the feeding jejunostomy. The only problem is it's more dependent on resource. It's an OR, you got to transfer the patient, or we have to get general surgery there to do it. It's just more complicated. But in a pre-surgical or sometimes in a post-operative patient, you just don't have the option, then that is the best option. And that provides excellent enteral access. The only problem is it's maximally invasive. We don't do them with IR, and if Robyn's on the line, she can comment on that. And we do them surgically. Most of the choices between gastrostomy and jejunostomy in a non-operative patient is really patient preference or resources. Like I said, it may be just easier for us to get them into a gastroscopy suite. But really, palliative versus treatment is the important distinction. And if it's to palliate, we tend to use the gastrostomy tubes. And if it's for treatment, then the jejunostomy tube is probably the better way to go. And I think a preoperative esophagectomy patient, everything is on the table. All the big ask would just be to include us in the conversation. And I think that a reasonable solution for enteral access is likely to happen. I did have I just wanted to put this because I sometimes had questions about a gastrostomy tube in a post-operative patient, like in a post-esophagectomy patient. And like I showed you before, there is no stomach that's in the belly. It's all mediastinal. So just to reemphasize that a PEG tube or an endoscopic tube is not possible in a post-esophagectomy or a post-gastrectomy patient. So that would have to be either a nasal route for enteral access or a feeding jejunostomy, which would be surgical. So anyway, I'll leave it at that. And if anybody has any questions, and I know if Robyn's on the line, she can talk a little bit more about the interventional aspect of things.
So I don't, is Robyn on the line? I don't